All right. Thank you all so much for joining our webinar tonight. Like I mentioned, my name is Nicole Murphy and I work with Minogue Medical, and so I will be kind of moderating for tonight. We have two wonderful speakers for you, and we're going to be starting in just a moment. Our first speaker is going to be Dr. Susie Lau. She is a gynecologic oncology surgeon who's going to be doing a presentation about surgical robotics. And then we're going to hear a talk from a patient as well. At the end of our presentations tonight, we are going to have the opportunity for a question and answer period. So if you have any questions that come up through the talks, I encourage you to write them in the chat throughout, and we'll make sure to record those questions to ask them at the end. So without further ado, we're going to get started. And so our first speaker is Dr. Susie Lau. She's an assistant professor appointed in the departments of oncology and obstetrics and gynecology at McGill University. She is the president of the Regroupement de Gynecologues Oncologues du Québec, and this is a society of individuals whose goal is the improvement of gynecologic cancer care in Quebec through education, research, and advocacy. Her research interests are diverse and include new investigational treatments and clinical trials in gynecologic cancer, as well as the application of robot-assisted minimally invasive surgery in gynecologic oncology. Thanks so much for being here today, Susie. We're looking forward to your presentation.
Thanks, Nicole. I think what I'm going to do is I'm going to share my screen. Can everyone see that? Okay, thank you so much for being here tonight and joining us. And I'm very excited to be talking to you about something I'm very excited about, which is surgical robotics in gynecologic oncology patients. First, I guess, okay. First thing is that I would like to disclose, I'm of course a gynecologic oncologist, and I have proctored gynae oncology surgeons and teams as they embark on the robotic surgery platform in Canada as part of the Minogue medical team. And without further ado, today we're going to be talking about demystifying robotics so that I can explain to you a little bit about what robotic assisted surgery is, as well as what is it used for and who is it particularly good for in the realm of gynecologic oncology. And then we want to talk a little bit about what's the state of the union and what's going on with robotics in Canada compared to other countries. So, first thing when I tell people that I'm a robotic surgeon, people don't really quite understand what that means. And so very typically what happens is people think of something like this. That some robot is literally operating on them. And in addition to that, the reality, it kind of looks a little bit like this. And the image in their mind is actually a little bit more Star Trek-y. But actually, it's not Star Trek yet. And so what I'm going to explain to you is really what we do. And so the bottom line is, even if we operate with a surgical robot, there is most definitely a real human surgeon that's operating the robot at all times. So the robot itself is a tool, and it's a tool to assist your surgeon. And so how does it work? It works such that there are robotic arms attached to a central podium, and through a remote console, which is, in most countries, in most ORs, it's just a few feet away from the patient herself. But at this console, the surgeon sits comfortably and is able to see in 3 dimensions, meaning they have a 3D camera view from a camera that's mounted on the robot, transmitting images to this console. And underneath here, where the arms are, you see these little controllers where the surgeon actually controls all of the 4 arms of the robot that you see here. And like I said, this is a high definition 3-dimension camera. And so that the rest of the team can see what we're doing, there's a vision card as well as screens throughout the operating room that also transmit exactly what the surgeon is doing and largely what the surgeon sees, but in 2 dimensions. Now, in real time, I guess this is what it looks like. If you see the patient on the right, what you'll see is the anesthetist at the head of the patient. There is the surgical robot that's usually beside the patient. The assistant, surgical assistant, either down here or next to the patient. You have a scrub nurse, and of course, the surgeon sits in front of the surgeon's console. And so through that console, this is exactly what it looks like underneath. The surgeon puts his or her hands through these controllers and at all times is manipulating the arms of the robot, whether they're the surgical instruments or even the camera. And so what are the advantages of the robotics platform? For the surgeon, it means that there's articulation beyond normal manipulation and precision like you've never seen. And what you can see here is the ability of this is a scissor that's able to rotate 7 degrees of freedom. So it's almost twisting 2 times what the human hand can do. And if you can tell up in the corner, the picture that you see here, you can see how fine our instruments are. And as a result, we can be extremely precise with what we're doing. In addition, there is the 3-dimension. In addition, there's of course the 3-dimensional view as well as magnification. Magnification is extremely significant. A surgeon normally, when they're operating on an open patient, can stand approximately about 1.5 to 2 feet, and some really tall surgeons will be almost a meter away from their patient in terms of where their eyes are and exactly where they're operating. However, with the view that we have with the robot, it's as if your surgeon's eyes got completely propelled into the abdomen. And so it's an unparalleled view. And at times it's so amazing that I definitely can say I see things that I've never seen before. In addition, of course, there's improved ergonomics. So instead of the surgeon standing next to the patient and operating for hours and hours on end, the surgeon gets to sit comfortably in a chair, being able to operate the arms of the robot and looking into the console. And finally, I think one of the most significant things robotics has to offer is this shorter learning curve. So what it means is your surgeon can definitely learn so much more quickly and master the instrumentation of the robots faster than any other technique, including laparoscopy. Now for the patient, of course, there needs to be advantages too. And what are those advantages? That would include smaller incisions. So we used to do surgery a little bit like this, where you have either a horizontal or a vertical incision. Now we do surgeries more with these smaller holes. And as a result, you can tell that smaller incision mean less pain and less scarring. Less pain means that people need less painkillers after their surgery. In addition, the smaller incisions mean there's actually less wound infection. And less wound infection, smaller wounds mean ultimately a much quicker healing time. So not only for the surgeon, but also and especially for the patients, the robotics platform is very important. So which specialties use this Da Vinci robot? Well, at the very beginning when this started, the 2 teams that were most involved were urology and gynecology. However, since that time, other specialties like general surgery, colorectal surgery, thoracic surgery, cardiac surgery, as well as head and neck surgeons also use the Da Vinci robot. And so in terms of the uses in gynecology, there's definitely a difference between general gynecology and gynecologic oncology. With respect to general gynecology, I'm going to go back. What is generally done is removal of the uterus, which is called a hysterectomy. In gynecologic oncology, we do the same. In addition, we remove the fallopian tubes and ovaries. In general gynecology, they can also remove fibroids, which are benign, and other benign conditions such as endometriosis. It's also used for pelvic organ prolapse and fertility surgery. However, as a gynecologic oncology surgeon, I mainly use the robot to remove the uterus and cervix, the tubes and ovaries, to remove lymph nodes, and any sites of cancer. And that means sometimes other organs, whether it be bladder or bowel or omentum, but for the purposes of removing cancer. And so there are different conditions in gynecologic oncology where we use the robot, and probably the two most significant at this time is the use in uterine cancer as well as ovarian cancer. And so the question becomes, well, we have this machine, it's a great machine, it's a great surgery. Does everybody benefit? And the short answer to that is yes. However, acknowledging that we have to be responsible about costs and so forth, are there particular populations where this technology is most beneficial? So we know that it's beneficial for a lot of patients and most patients, but are there ones who particularly benefit over and above? And those two populations would be patients who are obese, as well as the elderly. And I'm going to explain to you a little bit about why. And so, globally, we know that obesity is a problem and it's a challenge to surgeons. And, I don't have to tell you that it's actually almost in epidemic proportions in North America, especially. And how do surgeons judge how sizable a patient is? Well, if we look at normal patients, we would normally say that a body mass index or a BMI of less than 25 would be considered normal. However, we also know that in the range of 25 to 30 BMI, patients are already considered overweight. Between 30 to 40 BMI, patients are considered obese, and over a BMI of 40, patients are considered morbidly obese. And we know that now about half our population, at least the population who are having robotic surgery, are obese. And about 1/3 of all the patients that we are using the robot for are morbidly obese. And, the picture, of course, that you see here is a patient with a BMI of about 80, which is very sizable. And you can imagine the difficulties the surgeon could have, especially doing large incision surgeries on a patient like that. So how does the robot make a difference? Well, it makes a difference because we're not cutting through such large layers with large incisions. And as a result, with the smaller incisions, it's much easier for the patient to heal. In addition, the precision and the ability to manipulate that we have with the robot allows us to be able to do our surgery with almost overcoming the issue of all of the adipose and fat tissue. And so when we look at this objectively, what do we see? Well, in this little article that we had published, we're looking at comparing patients with a BMI of less than 30. So that's people who are not only normal weight, but also people who are just overweight, compared to patients who are obese in the middle column and patients who are morbidly obese. And so if we compare across the board, how long does it take for us to do the surgery? You can see that across the three groups, 226 minutes versus 232 minutes and 233 minutes is really not very different. In addition, EBL stands for estimated blood loss. And so if you can see across the board, 53 milliliters, what we're talking about is just a little more than about 3 to 4 tablespoons, okay? And that's all we're looking at in terms of blood loss for a standard surgery in endometrial cancer. And question, how long are these patients staying in the hospital? Well, this data that we have dates back to even the very beginning when we started robotic surgery. And what we're seeing is patients with a BMI of less than 30 are staying 1.4 days, and patients with a BMI of over 30 and even 40 are staying 1.6 days. So that means that they're not even in the hospital for 2 days, and you can see there's really no difference. And how about complications? Because nobody wants to talk about complications, but when we talk about complications, we talk about things like wound infection, urinary tract infections, etc. And if you look across the board, this is actually not very statistically different. And what about conversion? What's conversion? Conversion is when the surgeon actually can't complete the surgery robotically and anyway has to go and make a bigger incision. And if you can see here, the chances of converting once a robotic surgery has started is actually very low. And this is in comparison to when people are using laparoscopy, the rate of conversion is at least 25%. And in patients who are obese or morbidly obese, that conversion can go up to 50%. And so basically what we're saying is robotic surgery in patients who are normal or just overweight versus obese or morbidly obese is not different. And it puts everybody on an even playing field. What about the longevity boom? Because this is the other population that we think that surgery with the robot is very beneficial. And why is that? As patients get older, we know that they have more medical issues. We know that as patients get older, surgeons as well as other doctors who take care of older patients are actually rather scared to have them go under anesthesia and have surgery. And so, we looked at this patient population, and these are articles that have been published, and these are actually articles that our team has published on particularly this topic. So I'm going to give you a flavor of what that looks like. So if we look at patients in terms of their age, in the first column, you see patients who are less than 65, between the age of 65 and 69, and then from the ages of 70 to 80 and over 80. Overall, we had approximately 30% of our patients that were 70 or older. And what we do know about patients who are 70 or over is the ASA has to do with their comorbidities and other medical conditions. And of course, we know that as patients get older, obviously they're bound to have more medical issues, whether it's high blood pressure or diabetes, etc. They tend to be overall sicker. We also know that as patients get older, they tend to have more advanced endometrial cancers, and their endometrial cancers also tend to be more grade 3 or more aggressive cancers. However, very similarly to what we did with the patients who are more obese, we looked at the time it took for us to do the surgery, which is the console time, and you can see that across the board, there's really no difference. In addition, what about complication rate? Is the complication rate substantially different, whether they're minor little complications such as little either wound infections or little bladder infections, or how about the major complications? And that might lead to second surgeries and so forth. You can see that on the whole, these two groups tend to be very similar. And how about blood loss? Like I said, with respect to the blood loss, we were saying previously there were about 4 tablespoons. So in this situation, we're looking at closer to about, on the whole, 6 tablespoons, which is still not very much. And the chance of converting to an open surgery, if you look at the sort of younger patients, 69 and under, or over 70, again, you'll see that it's largely the same. How about length of stay? Length of stay in the hospital. What we were seeing is that people who are younger than 70 or older than 70 have roughly the same hospital stay. Patients who are 80 had slightly higher. So instead of 1.5 days, we're staying about 3 days. And the reason was more not because they needed to from a surgical perspective, but because we were rather uncomfortable sending patients home that early at that age, because oftentimes at that age, patients didn't have any help at home. And so we kept them an extra day to make it easier for them when they did go home. And so, like I was saying, 30% of our population is in that older age category, and they do tend to be sicker. But overall, we see that their experience having gone through robotic surgery is very similar to their younger counterparts under the age of 69. And so now I want to touch upon something that I am particularly passionate about, and that's ovarian cancer. And the reason is because traditionally ovarian cancer has been managed with the large incision surgery. The incisions running from what we would say stem to stern is what typically happens with ovarian cancer. However, what we have noted and what we've done in our team is we've taken the knowledge that we have that most ovarian cancers are very well treated with chemotherapy. And anyway, even if you do surgery, you still have to give chemotherapy. So what we did in our team was we started to give the chemotherapy in patients with advanced disease first. Many surgeons do that, but by giving it first, what we've done is we've allowed the chemotherapy to reduce the amount of tumor that the patient has. And so usually after 3 or 4 cycles of chemotherapy, we were then performing surgery, but then instead of making such a big incision, we use the robot with those 5 little holes to remove the rest of the cancer. And so what does that mean exactly? Well, in front of you is a publication that we had describing to people what our experience has been. And so if we look at having given chemotherapy to people prior, approximately 3 or 4 cycles, we had about 57 patients. 82.5% of patients had complete cytoreduction. And what does that mean? That means that the surgeon is able to say that they have removed all visible cancer. And amongst those patients, we also saw 17.5% of that population had disease that was less than 1 centimeter in its maximum diameter. And patients were not left with disease that's more than 1 centimeter. And this is really significant because what it means is we're actually not shortchanging patients at all by doing this type of surgery. Most significantly is the blood loss. When we look at usually those large incision surgeries, they are usually associated with blood losses of more than 500 cc's and many times much more than that. What we have is a blood loss of 135 cc's. So in that sense, you can say that it's probably about half a cup, which again is not very substantial. If we look at the rate of blood transfusions, it's actually quite low. And we oftentimes see blood transfusions hovering about 5%. Don't forget, these are patients who have had chemotherapy. So most often they will be anemic anyway, coming into surgery, and that's because of the chemotherapy. And so most of the patients who needed transfusions were not transfused because of blood loss during the surgery, but most were actually transfused because they were low to begin with, having had chemotherapy. The procedure time, on average, of course, it takes longer than an endometrial cancer surgery, but still it took on average about 312 minutes. And so that's about 5 hours. Primary debulking surgery with the large incision very frequently takes at least as long, if not much longer, with much bigger blood loss. And I think most significantly, people really need to take to heart that the time patients stay in the hospital is very short. And at the time when we published, patients were staying on average about 2 days. What COVID has done is COVID has really shortened everybody's hospital stay because, we tended to keep patients maybe a little bit longer because we were insecure. Having embarked on all of this surgery during COVID, what we found was that we were discharging patients much sooner and oftentimes even the same day, so that we minimize their exposure in the hospital. And we were able to do that because of these small incisions and because of the use of the robot. Now, it's fine that patients get to go home early, and it's fine also that they have less pain. And it's wonderful for the surgeons as well. But I think the most important thing to always look at is, we treat patients with cancer. And so as great as having a short hospital stay is, what does that mean in terms of a patient's survival? Okay, because if there's any compromise to a patient's survival, I don't think too many people would be interested in having this type of surgery. And so here is part of that publication where we're looking at patients who had the big incision surgeries prior to the robotic era and how they survived. And that's that blue line here. Okay. And patients in general had a survival of about 38 months. And if we look at open surgery during the robotic era, the survival again is about the same. Okay. With respect to robotics, we do tend to see a trend to having a better survival, in that patients having robotic surgery has a survival of 47.2 months. Now, is that to say that robotic surgery is so much better for patients? Not necessarily. And why I say that is because we select the patients that we will do robotic surgery on. These are patients who have tended to have had some reasonable responses to their chemotherapy. And so as a result, this is why you see these numbers slightly better. The important thing to note is that this number in terms of survival for patients is actually not less than these other two groups. So by offering them a surgery that leads to less pain, that leads to less hospital stay, less blood loss, less complications in general, we have not compromised at all on their survival. Now, let's go to another different benefit. I've talked to you about how good robotic surgery is for obese patients, for elderly patients, for patients with ovarian cancer. And this is a pretty new area, if I can say so. Although we've been doing this for the last 10 years, in the community of GYN oncology, it's relatively new, and it's really picking up because of COVID. But let's talk about some other benefits that other people oftentimes don't think about, and that's the pain and costs. So in this paper that we published, we talk about how the robotic surgery has allowed us to use the minimum of pain medication and how it associates with the cost. So here, what we're trying to show you is that on post-op day 0 is the day that the patient has surgery. Post-op day 1 is the day after surgery, and post-op day 2 and onwards, this is what patients were getting. And so if we look at these bars, the blue bar are patients who had the large incision surgeries, and the red bar are patients who had robotic surgeries. And so globally, what you'd see is that the amount of acetaminophen or Tylenol that these two groups received is about the same. Ibuprofen is a non-steroidal anti-inflammatory, not a narcotic. And what you see is that the robotics group needs less of the ibuprofen, but tended to need a little bit more naproxen, which is also another non-steroidal anti-inflammatory. But if you look at post-op day 0 to post-op day 1 and onwards, you can see that even for non-opioids, patients who had laparotomies in the blue compared to patients who had robotics in the red, as the days went on, they still required a lot of relief from their pain with non-steroidal anti-inflammatory medication. Let's look at opioids, which are what we would consider narcotics. Narcotics such as morphine or Dilaudid. And what we would see is on post-op day 0, on the day of surgery, laparotomy patients need more than robotics patients in terms of opioids, as well as on post-op day 1 and post-op day 2. And so just by looking at this, I think you can clearly see that the amount of pain must be less if they need less painkillers. And so what we saw was, of course, patients needed overall less analgesics, whether they were opioids or non-opioids following their robotic surgery in comparison to conventional laparotomy. And that would include both the population and elderly and obese. And this resulted in diminished pain medication use, which is associated with cost savings. Other than just the financial costs, I think it's also very important to acknowledge that, especially in the elderly population, you really don't want them to use too much narcotics or opioids to control pain, because opioids in general do things like lead to drowsiness and increase the risk of falls in the elderly, and as well tend to cause the bowel to move in general more slowly and allow patients to recover less quickly from their surgery. And so let's talk briefly about the costs of robotic surgery in gynecologic cancer, or actually what I would really want to tell you is that robotics is cost savings in treating gynecologic cancers. And so I'm going to put this in the Canadian context, and that's where we are right now. If we look at 3 conditions for which we use to treat gynecological cancers with the robot: endometrial cancers, cervix cancer, and ovarian cancer. And if we look at how much it cost before we got the robot, and then how much it would cost to do those surgeries in the era of robotic surgery, you can tell that whether it's endometrial cancer, cervix cancer, or ovarian cancer, it is a cost savings, right? And this is, in another graphical form, the savings that we were able to have treating cervix cancer over the 12 years that we calculated that we had the robot. For just cervix cancers, we saved over $500,000. In ovarian cancer patients, we saved over $1.5 million. And we calculated that for endometrial cancer patients, we saved over $3.5 million because of the use of robotic surgery, because patients were not having many complications. They were not staying for longer periods in the hospital. And so how does this compare across Canada and to other countries? If we look at our neighbors in Ontario, in general, there are 13 surgical robotics programs in Ontario. They've had since 2003 treated about 15,000 patients, and of those, about 2,500 were robotic assisted hysterectomies in Ontario. And below, you can see the distribution of all the hospitals that have the robot in Ontario. In Quebec, which is where I am, of course, we have a total of 8 surgical robotics programs in Quebec. And since 2003, treated over 13,000 patients. And in terms of hysterectomy, 4,300 of those 13,000 patients were patients who had hysterectomies. And you would see that most of the robots are located in Montreal. However, there is one in Sherbrooke and one in Quebec City. The very first hospital that had a robot was the very first hospital that had a robot was actually Sacré-Cœur, or Sacred Heart. And since that time, of course, in Montreal, we've grown a little bit. How about in general? What does it look like in Canada? Well, there are programs, of course, in 5 provinces in this country: Quebec, Ontario, British Columbia, Alberta, and Nova Scotia. And that means 13 cities in total. Overall, about 41,000 Canadian patients have been treated with robotic assisted surgery since 2003, and over 200 surgeons are trained to safely perform these surgeries in Canada. Now, in the United States and around the world, these numbers are very different. In the United States, as of March 2020, there were 3,581 robots. In Europe, 93. In Asia, 80. Remember, we said in Canada, we had 42 robots. That means in Canada, there are 30 robots in Canada serving 37 million people. So that's 1 robot for 1.2 million people. If we compare it to our neighbors to the south, there are over 3,500 robots in the United States for 328 million people, which is 1 robot for 92,000 people. So in Canada, although we are 10 times smaller than the United States. We are 100 times smaller from the point of view of having robots compared to the Americans. This is, I hope, the presentation that I've just given you helps you to understand a little bit from a surgeon perspective, how we feel that we could do better in Canada from the point of view of being able to offer robotic surgery to patients in general. And that's primarily the purpose of this talk, so that those of you out there understand a little bit about what we live as surgeons, and myself personally as a gynecologic oncology surgeon. And for those who have had experiences with robotic surgery, of course, I hope that it was positive. For those who are going to have, I hope the experience will be very positive. But I think the question becomes, can we actually get this technology more out across Canada so more people can benefit? And so as a quick recap, I just wanted to talk to you about the overall benefits, of course, of robotic surgery for surgeons with respect to endurance, so that of course, surgeons are able to operate for longer periods of time with less fatigue. They're able to operate more precisely based on the computer interface, the fine instruments and motion, as well as the three-dimensional vision. And when we look at the results are similar, if not better, than when patients have open surgery. And that also includes patient satisfaction and comfort. And overall, remember, a happy patient is a happy surgeon. A happy surgeon also equals a happy patient. And when we look at the benefits for the patient, we know that robotic surgery leads to less pain with smaller incisions, less blood loss and fewer blood transfusion, less risk of infection, a shorter hospital stay, less opioid use, and that means, of course, a faster recovery and quicker return to their daily routine. And so it's a no-brainer that we save money overall with the robotic surgery compared to open surgery. And so I would propose to you that the future is now. And we used to be like this. We then became laparoscopic surgeons, but today we are like this. And I would say that this is definitely where I prefer to be. I'd like to thank you for your attention. And this is a little picture of our team. So a little thank you from our team to you. And now I think, would it be okay now to take some questions, or should we wait a little?
Thanks so much, Dr. Lau. If you don't mind, we'll wait until after Minot has had the chance to speak, and then we'll do questions all at once.
Yes.
Perfect. Thank you so much for your time and for your presentation. I think that was really exciting for a lot of people, and we're looking forward to taking questions after Minot has had the chance to speak. But if you have any questions now, I encourage you to put them in the chat, and we'll make sure to get to them at the end. But without further ado, we're going to pass the mic over to our second speaker, who is Minot, who actually was a patient of Dr. Lau's and received a robotic assisted hysterectomy. So Minot, can you tell us a little bit about your story?
Yes, first of all, hi everyone. I must say I'm a very lucky one to have Dr. Lau as my surgeon in my case. She just saved my life. I've been diagnosed for ovarian cancer a year and a half ago, and she take care, with the chemo and all. She said it's exactly the way I went through. It was exactly the same way she presented. I got the operation done after 4 treatments of chemo, And then we expected at the time to have a 4-hour operation, which took finally, I think, double time, because I have more they expected of the cancer to remove everything, which they did. And but what I was totally amazing about is that when I woke up, no pain. No pain at all. They wanted to give me painkiller. I didn't need any. I would have been going to work. I worked the day after, so to give you an idea. So I was very impressed. I feel good, and I feel very confident about to be ill, because I had very good care. They took out all the the cancer I had inside, and now I feel so good. I even swim every two morning at 50 laps from my 25-meter pools, and I feel good, and I just want to travel again. I just wait the COVID to go and to get back to, I'm an editor, and I like to discover new things and to share it. So that's it, and it's so amazing, because it was my second cancer for my story, and it was a stage 4, and I had a lot of metastasis in my stomach, my abdomen, I think. Sorry, my English is not as good, but no more. Everything, all the results are good, and so if I have any question, don't hesitate to ask me. But I was very impressed, and I feel so confident about it, because first they explained everything. It was exactly not as much as I learned today and what they explained with but I feel comfortable, and I feel that I had one of the great, and no scars, just little things, and I can go work the day after. Can you imagine? That's it.
That's incredible.
Yeah, even the 2 after treatment of chemo, I said, do I really need it? So, but I follow the order.
That's fantastic, Mano. Thank you so much for telling us a little bit about your story. And folks in the audience, if you have questions for Mano as well, I encourage you to put them in the chat as we go into the question and answer period as well. So before we answer questions, I'm just going to share my screen one more time to show you where the best spot is to put your questions. And so that's going to be in the chat function. So this is an image showing you where that chat option is. And you just click chat at the bottom and open up the chat box on the right. Excellent. So I do have a couple of questions that we'll get started with. But as we talk, I encourage you to enter questions again into the chat as we go. So the first question is for Dr. Lau. Why isn't everyone using the robot to perform hysterectomies in Canada?
I think it's really a matter of accessibility to the robot. As you can see, across our country, we have 42 robots to serve 37 million Canadians. And so it's simply a matter of access. And I can tell you that across Canada, virtually all centers except of one that I know of have had their robots purchased, not from the funds from the Canadian government, but really the robot was purchased from private donation funds to the hospitals where the robots are. And that's, I guess you can say, for us at the JGH, we are lucky that we have generous donors that were willing to support equipment like that to allow us to be able to offer really state-of-the-art care to our patients. And unfortunately, many centers across Canada just don't have that level of philanthropy, I guess. And our government hasn't yet bought into the concept of how it saves money, but it's actually so much better for patients. And that's one of the reasons why we need to do sort of webinars like this, so people out there know what's involved, and maybe they could be advocates for technology like this as something that would be useful for their own healthcare or people they love.
Excellent, thank you. Our next question is for Mano. You said you were working the next day, but can you tell us a little bit about how you were feeling like 1 week later? Were you back to normal activities, or how long did that take?
Yeah, but I can say that I was doing physical activities, but I was able to walk, to go upstairs, and to do my regular activities, such as working and being attentive. And no, I feel very good, in fact. Very, very good.
Excellent, thank you. Dr. Lau, coming back to you, there was a question on if the wait list time is longer for robotic-assisted surgery versus laparoscopic surgery.
Actually, no. I think the wait time depends on each department and how they gauge priorities. However, what I can tell you is that, you know, this past year with COVID, the one thing, despite all of the cutbacks in terms of surgery at all of the hospitals, the one thing that's really kept us operating was the fact that we did robotic surgeries and our patients didn't need to stay in the hospital. And so most of our patients were going home the same day or at most the next day. They didn't need any ICU beds. They didn't have any long hospital stays. And as such, it kept us operating. So with COVID, the robot has been a godsend.
Excellent, thank you. I was also wondering, is there any additional cost to the patient if they choose to go with robotic surgery, robotic-assisted surgery, as opposed to open or laparoscopic surgery?
So actually, there, in all of the centers that I know of, there is no additional cost to the patient. There have been provinces where they did try to balance their own budget and make it possible for themselves to be able to do this surgery by asking patients to pay the extra costs on top of doing robotic surgery. However, all of the centers, as far as I know, across Canada have stopped doing that. And so robotic surgery is offered to patients at no additional costs. And in our hospital, our foundation has been generous enough to support us in that endeavor.
Excellent, thank you. I have one last question here, so I'm just going to make one last reach out for entering any questions you have in the chat, or we're going to start to wrap up and conclude the webinar. But my final question is for Mano. How did you hear about robotic-assisted surgery, or did you do any additional research before making your decision?
For me, I'm not a fan of doing all the research when you learn a diagnostic like that, because you can find all information and without somebody specialized to give you and to confirm some, it's, you know, it just makes you crazy. So I just go with my Dr. Lau team, which are the best. I told you. You have to be treated by them if you're sick. If you want to survive, they're really exceptional. I'm very touched. Even all the team they work with, they explain it to you, and she's the one that told me the procedure, and I was crossing my finger that they could, because sometimes they have no choice than open and to do the regular, depending what it is. But it went good in my case, and I'm very glad about it. And all the time, I trust the team. You know, I follow what they say, and everything went good. So they're the specialists. So that's it.
Excellent. Thank you. Excellent. So that